Hello students, welcome to Chapter 11, which covers co-occurring disorders, COD, with substance use disorders. Before we begin the chapter, there are a couple of handouts you might want to go ahead and print out or have with you during this chapter. One is the infographic on co-occurring disorders or comorbidity. The other handout is called the 4 quadrants of co-occurring disorders. And the last handout has to do with the definitions of depression. So let's begin the chapter. In this chapter, you will learn to define co-occurring disorders, identify the number of people who suffer from serious mental illness, also known as SMI, and explain the differences between a depressive disorder and an affective disorder. You will also be able to assess the depth of depression disorders using the criteria of severity, frequency, duration, and precipitating factors. Next, you will be able to describe the diagnostic criteria, the differences between the affective disorders. You will describe and identify the common characteristics of the manic phase of bipolar disorder. You will be able to explain the difference between a personality trait and a personality disorder, and you will explain the relationship between personality disorders and substance use disorders. 2 of the personality disorders that are most commonly associated with substance use disorders are antisocial personality disorder and borderline personality disorder. Unfortunately, there is no easy fix or treatment for personality disorders. There generally are no known medications to resolve personality disorders. Co-occurring disorders, especially with personality disorders, are very difficult to treat, but not impossible when they occur with substance use disorders. You will also be able to define narcissistic personality disorder and describe how alcohol and drug use complicates the disorder. You'll be able to explain the role of trauma in co-occurring disorders, and we will work a little bit with the American Psychiatric Association questions for the treatment of psychiatric disorders. Co-occurring disorders is when one or more psychiatric disorders exist along with at least one substance use disorder. So you may have 2 psychiatric disorders, such as anxiety and depression, along with 2 substance use disorders, such as alcohol use disorder and cocaine use disorder. All diagnoses should be recorded into the client's electronic health record. In addition, there are low severity and high severity of each of the different disorders. So take a look at that quadrant model of co-occurring disorders handout in the Files menu under Handouts. You may have a low mental health severity and a low substance use disorder. You may have a low mental health severity but a severe substance use disorder. For example, a severe alcohol use disorder results in a mild anxiety mood, especially, of course, when they slow down on their drinking. You may also be looking at a high mental health severity, but low substance use disorder. For example, maybe your client smokes marijuana to cope with the voices that they hear in their heads from the schizophrenia. Or lastly, the fourth quadrant, you may have severe mental health symptoms and severe substance use disorders. Obviously, with the high quadrant, it is the most difficult to treat and requires lots of coordinated care. Dual disorders or comorbid disorders or even co-occurring disorders may be too simplistic of a description. When we're talking about high and high severity and multiple mental health and multiple substance use disorders, basically we are talking about complex clients. Your textbook still has some really old data, but the statistics demonstrate that females are most likely to have co-occurring disorders. It is possible that males are only diagnosed or are only assessed for substance use disorders and may not disclose or acknowledge any mental health symptoms. The numbers for males, therefore, are probably underreported. See the infographic in the Files menu under the Handouts under Chapter 11, which illustrates on this graph the new figure where it says 4 million. In 2017, that number has now risen to 7.7 million people suffer from co-occurring disorders. And the infographic has the most current updated statistics. There are more detailed information in the Files menu under Handouts under Chapter 11 if you are interested in the topic of co-occurring disorders. Just a reminder that this is an introductory course, and so we are just touching lightly on many topics associated with Intro to Addiction. But you do have the opportunity to do more research and reading on the topic of co-occurring disorders. When depressive feelings persist beyond the common period of time to work through them, an affective or feeling disorder develops. The different types of depression are differentiated based on severity, frequency, duration, and precipitating factors. Many individuals are frightened to be labeled depressed or manic depressive or with other affective and mood cycling disorders such as bipolar disorder. Some clients self-medicate with the use of alcohol and drugs in an attempt to avoid the shame with their underlying psychiatric condition. A depressive disorder has a known etiology, gets progressively worse over time, and has significant negative consequences if untreated. Therefore, recognition of the underlying depression is important in working with clients with substance use disorder. It got me to thinking a little bit about grief and depression. A client may experience grief when they lose something or someone that is important to them. And a lot of folks would say becoming abstinence or giving up their drug or alcohol may invoke a grief reaction or a loss of that lifestyle, of those former friends, of the feelings of being high. So grief and depression, what are the differences between those? Well, grief, we can identify why the person feels sad. They will say, I lost all my friends. I can't no longer hang out with the old crowd. Grief comes in waves. If guilt is present, so for example, my drinking took me away from my kids, it is usually related to the loss. They may also wish to die, to join the deceased if it was an individual, but they may not be actually suicidal. Whereas depression doesn't identify a specific cause for depression. Depressed mood is unremitting. So this looks like the person is crying or sad or can't get going and they don't really know why. You ask them what's going on and they just say, I don't know, I can't figure it out. And the depressed mood seems to be just kind of going on and on and on. Generalized feelings of guilt and low self-esteem are evident also in depression, and the person with depression, as opposed to grief, the person with depression is more likely to be active suicidal. Now, this is a little bit of a description of the categories of mood disorders. These are the 6 categories of mood disorders with predominantly depressive features. We're going to go through each one of these categories in the next few slides. Major depression may occur as a single episode or as repeated episodes over the years. There are many bodily signs called vegetative signs of depression. And what are some vegetative signs or body signs? Sleep patterns, appetite, weight, libido, sex drive, cognitive functioning, and inability to experience pleasure. So those are the signs and symptoms of major depression. Dysthymic disorder is a mood disorder of longer term than major depression, but it is a lower grade or a lesser depression. These symptoms of dysthymic disorder is symptoms of depression, anxiety symptoms, headaches, and muscle tension are frequent. Dysthymic disorder usually can go undiagnosed since it is generally less intense, less noticeable than major depressive disorder. Atypical depression is a diagnosis that sometimes is used for many adult children of alcoholics. Patients experience intense and sudden depression in response to interpersonal loss or threatened interpersonal loss. and they usually have an increase in appetite and an increase in sleep. You may remember from our reading on adult children of alcoholics that many of those experience conflicted feelings when the parent who was the alcoholic or the parent who was the codependent perhaps dies or becomes ill. And so a typical depression may be present in those adult children. In organic depression, this usually occurs as a result of a brain tumor, a head injury, nutritional deficiencies, physical illness, or alcohol and drug use, which may result in actual organic brain damage, and then a depression is exhibited. Bipolar disorder. Bipolar disorder is the highest affective disorder associated with substance use disorders in a co-occurring. Common themes with clients who have bipolar disorder and substance abuse. There's a strong emphasis on depression as opposed to the mania, and a predominance of hopelessness. There is a specific pattern of medication non-compliance for the bipolar disorder, and instead the patients tend to label their substance abuse as self-medication. So it's interesting how the two, bipolar and substance use disorder, kind of interplays with each other. Depressive disorders, of course, may lead to suicide ideation, suicide attempts, and actual suicide completed. The combination of depression and alcohol and drug use places patients at high risk for suicide. Feelings of shame contribute to the vicious cycle. Some individuals self-medicate their feelings of sadness and pain rather than go down the path of self-destructive action. It is very important to continually check for suicidal thinking when we are working with a client who has depression and a substance use disorder. We will cover suicidal clients and crisis assessment and crisis interventions later in this chapter, and your posting in the discussion forum is on handling suicidal clients. Look in the Files menu under Handouts in the chapter for crisis assessment and crisis intervention. Personality traits are a lower grade and less stable symptoms than a personality disorder. Antisocial personality disorder and substance use disorders are estimated to be found in 2 to 3% of the male population. Antisocial personality disorder has the strongest relationship with substance abuse, and the most common additional diagnosis is criteria for antisocial personality disorder. And usually this diagnosis is predominantly attributed to men. There are also conduct disorders attention deficit hyperactivity disorder, ADHD, which can be addressed by early assessment, intervention, and counseling. Individuals may not consider the personality trait that is causing conflict as undesirable, so they might attribute others' complaints about them as fault of the other person. Alcohol and drugs provide immediate gratification, followed by regressive behaviors. So an example would be that my brother always complains about me verbally abusing my wife. Well, he doesn't know or me or my wife very well, and he probably thinks all men are abusive. I don't consider myself abusive at all. I just need to show my wife who is in charge of the family. So that's kind of an example of where they don't consider their own behavior as problematic and complain about others instead. Borderline personality disorder, of course, has a really bad reputation, but that is because the personality traits are very difficult to get a handle on. The person with borderline personality disorder has intense mood instability. One minute they love you and you are the best counselor ever, and the next minute you are the most hateful counselor. How can you ask me to go to AA meetings? Don't you understand me at all? They want closeness and trust, but fear it too, so much that they would rather leave than risk the closeness. I hate you, don't leave me. Abstinence from drugs and alcohol is essential when working at the same time with long-term psychotherapy that is needed for borderline personality disorder. The evidence-based practice for treatment of bipolar borderline personality disorder is called dialectical behavioral therapy, DBT. Some questions that may help identify abandonment issues that you may choose to want to explore with your client. Some would say that borderline personality disorder results from some childhood abandonment issues. So the questions might be things like, did you have parents who were not open or available to you physically and emotionally? Have your parents attacked you verbally or physically or blamed you for many of their problems? Was your sense of self discounted or violated by your parents? Were you disregarded, ridiculed, blamed, and teased? And were you made to feel that your fears were unwarranted or inappropriate? If so, abandonment or trauma may result in a personality disorder with long-term effects. You may see a narcissistic personality disorder associated with substance use disorders, although it is generally less associated with SUD. Remember, the borderline personality disorder and the antisocial personality disorder are the two most commonly associated personality disorders with substance use disorder. Sometimes the trauma comes first, like in childhood. And then the client develops a substance use disorder in order to cope with the trauma, and then they become depressed. This is also called the self-medication theory. Sometimes the substance use that perhaps began in adolescence or young adult contributes to the young adult acting out, which puts them in risky situations wherein they may be traumatized, such as the case of being raped or domestic violence. The outcome is really that it doesn't matter which came first, the trauma, the mental health issue, or the substance use disorders. What matters is the recognition that there is a high likelihood that they, all three of those, exist at the same time and need treatment at the same time. We used to say that one disorder was primary over the other, but again, it doesn't really matter. Self-medication or not, that really doesn't matter. What matters is that the treatment is holistic. It covers all three and integrated at the same time by the same team. As with any other treatment and counseling relationship, the first step is to establish and maintain a therapeutic alliance with the client. The client needs hope and someone with whom they can feel that they can work with to get better. You will also provide education to the clients regarding the different diagnoses and information about available treatment. The client should clearly understand what is the treatment plan, who will be providing the treatment, whether or not family members will be involved in the treatment. What are the different medications that are available to help? Now, you don't need to operate outside of your own scope when talking about medications, and you may not be knowledgeable about the different antidepressive medicines, for example, but your role is to get the conversation going between the medication's prescriber and the client. It may be valuable for you to attend the MD or psychiatrist appointment or meetings with the family to explain what the client is experiencing and the symptoms that you are seeing. Integrated treatment is an evidence-based practice. Let's define some terms related to co-occurring disorders. Sequential treatment. Sequential treatment is one treatment that follows the other. For example, in the older days, you needed treatment for the substance use disorder first because the client needed to be clean and sober. They would say for at least 6 months or a year until they could possibly benefit from mental health treatment. In addition, we certainly did not want to substitute one medication, even if a psychotropic medication, for the drugs and alcohol. Again, sequential treatment is old thinking. It's not the best practice. The next best thing perhaps is concurrent treatment. And what we notice in sequential is that some people with one treatment following the other, some people could not ever even get sober for 6 months or a year, and they would keep relapsing and relapsing, and it appeared that their mental health issues i.e. the depression or the trauma, was interfering with their sobriety. Therefore, they could never ever get clean and sober. So we moved to a concurrent treatment then. Concurrent treatment is that both treatments, mental health services and substance use disorder services, occur at the same time. Not necessarily in the same place or by the same provider. So in concurrent treatment, the client would go see the psychiatrist on one day at the MD office and then go to mental health to get their mental health counseling, and then go to county drug and alcohol services all on different days to get their SUD group counseling. That was called concurrent treatment. And as you can imagine, clients were ping-ponging and different providers only had different parts of the story. If integrated treatment is not available, concurrent treatment would be the next best thing. And in concurrent treatment, though, sometimes there would be communication problems among the providers. There needed to be more coordination in scheduling all these services, and how's the client going to get over here and then over here and then over here. And we needed to have agreement on common treatment plan. But sometimes there's not enough coordination in concurrent treatment. And sometimes the mental health therapist didn't even know if the client was going to the SUD group counseling or what was happening in the SUD counseling, and even if the client was testing positive or negative. Well, integrated treatment is the ultimate goal and an evidence-based practice for COD. Integrated treatment is when the mental health therapy, the medications, and the SUD counseling all occurs at the same time by the same provider team and with a single treatment plan. One person, one plan, one place. The integrated treatment team meets together on a regular basis, and while the treatment providers are multidisciplinary team members, so there is a doctor, there might be a psych tech, a nurse, a therapist, case manager, they all have access to the same information about the client and the client's treatment progress. The services also complement each other. What is being taught or experienced within the SUD group counseling then is complemented by what is talked about in the individual therapy sessions. There is no sense that one disorder is more important than the other disorder. Both disorders exist at the same time, so both must be treated at the same time. During this course, you have learned how substance use disorders affect children and what are some of the characteristics of an adult child of an addict or an alcoholic. You have also learned and have discussed about the importance of family involvement in the treatment and recovery of clients with co-occurring disorders. Some problems that exist with substance use disorders appear to be internalizing problems, such as depression, anxiety, trauma disorders, and suicidal thoughts. While other problems associated with substance use disorders appear to be externalizing problems, meaning they are more viewable to the family and friends of the client, including conduct disorders, ADHD, physical violence, antisocial personality disorder with criminal and illegal activities. Frequently, alcohol and drugs impair judgment and influence suicidal ideation and behavior. So the right combination of trauma, stress, loss, depression, isolation, health problems, interpersonal or spousal conflict, financial, occupational problems, and alcohol and drug use may lead to feelings of hopelessness and shame, making the individual more vulnerable to suicide. Before you're posting in the discussion forum, again, take a look at the file menu under the handouts to review the materials on Chapter 11, including crisis intervention. What steps should you take when the client feels that they might hurt themselves? What are the plans that need to be put into place? Can you break confidentiality? Who should you tell? What are the resources that are needed to be put into place since you can't be with your client 24/7? On the other hand, some clients with co-occurring disorders may act out or threaten or harm others, such as domestic violence or a Tarasoff situation. So here, what are the steps that you need to take with the client to prevent the victimization of others? What steps would you take to assist the client? When can you break confidentiality, and who do you tell? Planning ahead and knowing the steps to help your co-occurring client who is experiencing a crisis will be very important to practice ahead of time.